Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
My name is Claudia Vasquez, and I'm the Associate Vice President of Philanthropy with Sun Health Foundation. Welcome. And first, of course, a big thank you to the Colonnade for hosting us in this beautiful space. And I'm curious to know, how many of you, is this your first time to Coffee Connections? Can you please show me your hands? Any first timers? Oh, a few of you. Thank you. Thank you so much. Appreciate you being here. So, for that reason, is that we'd like to share a little bit about our story, and I know many of you know it, but if you'll just allow me, it'll be brief. Our story goes back 60 years when a group of thoughtful, community-minded Sun City residents came together with a big idea. Let me make sure I put a slide up here. You can't hear her. To build a hospital for their growing retirement community. Thanks to their vision and land donated by Mr. Boswell, the Boswell Memorial Hospital was created. As the area kept growing, the community stepped up again about 18 years later to help build the Del E. Webb Memorial Hospital. Sun Health operated both hospitals up until 2008, when later they were merged to the Banner Health network. By the way, I'd love to say a huge welcome to our Banner professionals over here joining us at this table. Thank you. In addition to, of course, our speaker today. So, in addition to that, Sun Health, as I mentioned, we operated these two hospitals. We transitioned them to a Banner network. However, Sun Health remained as the exclusive philanthropic partner for both hospitals. In addition to that, our donors can also support through the foundation, the Banner Sun Health Research Institute. Our donors make programs possible through our Center for Health and Wellbeing, programs such as health and wellness classes, nutrition programs, our Memory Care Navigator, which walks families through the dementia journey. We also support nursing scholarships. All this helps grow the next generation of caregivers. And all of this work supports one big goal, which is to help our community live healthier, longer, and better. And that brings us to why we're here today. Coffee Connections is our way of keeping you plugged in to what's happening in health and wellness, straight from the experts, and giving you the chance to meet the incredible providers serving our community with the hospitals we support. With that, I'd like to introduce our presenter, Dr. Daniel Nethala. He is a urologic oncologist. He specializes in genitourinary surgical oncology, helping patients make informed decisions that align with their goals while supporting them through every step of treatment and recovery. Dr. Nethala completed the Urologic Oncology Fellowship at the National Institutes of Health, followed by a urology residency at the Donald and Barbara Zucker School of Medicine, and earned his medical degree from Temple University's Lewis Katz School of Medicine. Please join me in welcoming Dr. Nethala.
Thank you. Thank you so much, Claudia, for the kind words, and thank you, everybody, for coming today. Happy to be here, and started, I think, about 6 or 7 months ago at Boswell, and we're kind of expanding our scope of care practice, and this is what I wanted to go over today. Common urologic malignancies, and to kind of show you the numbers and to show you how common these things are and kind of some early warning signs to think about. to just present to your doctor or to possibly see a urologist. So what we'll cover today is kind of the four major cancers of urologic malignancies. Some more apply to men, but obviously kidney cancers and bladder cancers affect women as well. So we'll go over that, risk factors. We'll go over what these cancers are, and we'll leave it open for questions afterwards if anybody has any questions. So why are urologic cancers important to think about? They're really common. So about 400,000 cases annually affecting both men and women. They affect men a little bit more than women, but still really important for women to think about. They're some of the most common cancers diagnosed, so kidney, bladder, prostate, ureteral, adrenal, and urethral as well. So prostate cancer for men is obviously the #1 cancer in men, and the second most common cancer cause of deaths in men. There's about an 80% survival rate as long as you can find these cancers. And hence why we should be screening for them earlier. And then 40% of them are preventable. So for the men in the room, what is prostate cancer? Why do we hear about it all the time? Why is there so much stuff about this? It's really common. About 1 in 8 men are diagnosed with prostate cancer every year. You can see there's almost 250,000 cases annually. It's really, it can be treated really well. Most men do extremely well and almost have no change in their life expectancy if they're diagnosed with prostate cancer. But what are the risk factors? So some of them I have listed on the left side, but it's usually age, race and ethnicity. So people of African American ancestry are found to have higher risk prostate cancers and may have worse outcomes. We're not entirely sure if that's genetic or if it's just due to poor screening, but we're looking into that still. Family history is very important, so if anybody has a family history of like a brother, a father, or a direct family lineage to prostate cancer, it's been found to be heritable for a multitude of different genetic reasons. So for those reasons, you should always tell your doctor if you have that. Diet, they've been looking into this pretty recently, but there's a lot of good data that says, eating less red meat, more fruits and vegetables, less salt, things like that, are good at preventing prostate cancer. And if you're diagnosed with prostate cancer, it helps prevent it from progressing. And obesity, like a lot of malignancies, is linked to prostate cancer. So what are the warning signs? There's not always a lot of warning signs, hence the screening recommendations, which we'll go over pretty quickly. Some of these things are related to the benign enlargement of the prostate, so frequent urination may occur, weak stream may occur, frequent urinary tract infections, blood in the urine or semen is a possibility. I think these other two are also just possible, just things to bring up with your doctor. If you have pain in the bones and the hips, that just sometimes prostate cancer likes to spread, and if it does, it goes to the bones. And then erectile dysfunction, which may not be related to prostate cancer, but just maybe something that you can see. So how are we screening for it, and what should we do? I'll go over some of the age recommendations. So what is PSA? I think a lot of people hear about it. It's just a protein made by the prostate. It's probably the best biomarker in all of oncology across all specialties, but it's not perfect. It's just a protein that we measure. Above certain thresholds, we pursue further investigations with either MRIs or possibilities of a biopsy. So, usually between 4 and 10, that's when we tell people to get, to have further investigation into what's going on. And above 10, you should definitely see a urologist. Below, I have some of the, when do we start screening people for prostate cancer? Again, if you have a family history, you should start earlier. If you're African American, you should start earlier, and then generally about 50 years old, we start screening men yearly or every other year with PSAs. But what are the guidelines for, prostate cancer generally happens to older men, so 70s, 75s, late 60s, what should we be doing? We used to overtreat prostate cancer, so we used to find a lot of low-grade prostate cancers that were more like chronic diseases, and I think we harmed a lot of people before. So a lot of this is kind of balancing the scales and seeing, who's at risk, who actually needs to be screened, and kind of acting on that accordingly. So we do not routinely screen men over about 70 if they don't have a long life expectancy due to other medical comorbidities, because the truth is, regardless if you have prostate cancer, you're gonna, something else may happen in that time period, and treating it wouldn't change your trajectory or your life expectancy. Screening for men that are in excellent health in like their 70s, 75s, and or 80s could be appropriate if you're in excellent health and you have parents that live to 100. I think that's well worthwhile. So it really just depends on the patient. And then over 75, if you're at average risk, a lot of times you can just talk to your doctor, because you don't need, at a certain point, if you had a biopsy, if you've been screened and it's never been too high, you may not need to do anything. But it's all a risk-benefit kind of evaluation. We went over again on the right side, why does life expectancy matter? It's because prostate cancer is just very slow growing. So you need to have a long runway essentially to make any tangible difference. So I'm not going to go over this, but again, these are kind of the guidelines for screening for PSA. So it's very variable. It really depends on the person, and it's just something you should talk to your doctor about and kind of see where you fall. This is just the basics. What do we do for the further investigation if you have an abnormal PSA? Usually we repeat the PSA. Someone can do a digital rectal examination. Some of that has kind of fallen out of favor because a lot of times now we do an MRI of the prostate, which can find kind of tumor nodules and can direct care. And then if you have something very suspicious, you can go for a biopsy, and then getting tissue will decide, what is needed. 2. So kidney cancer. So again, this affects men and women both. Obviously, all of us have 2 kidneys. But this one is very silent. This one a lot of people do not find. And this is why I want to kind of shed some light on this. If you see some of these warning signs, this is something you should get investigated. So about 30%, I think this number is actually even higher, it's probably around 50 to 60% are found incidentally. So a lot of times people go to the ER, they stub their toe, they get a CAT scan for whatever reason, and they find something on their kidney. About 20% of masses found on the kidney are just benign, so just normal, non-cancerous growth. But the survival is very good. It's a little more common in men, but there are a lot of cases of this. So what are risk factors for kidney cancer? So smoking, like a lot of things, can raise your risk. Being obese, high blood pressure, and again, family history. There's some of this has fallen out of favor in terms of occupational exposures. A lot of people who are exposed to like aniline dyes and things like that were at higher risk, but a lot of people don't even know what those are nowadays. So really the most important things to know, again, are you generally don't, a lot of people can even have large renal masses and not know. But the really important things, I think, are any blood in the urine ever is not normal. And even if you're on a blood thinner or anything, if your urine is pink or reddish, you should be evaluated. And we'll go over bladder cancer next in a second, and that is more of a hallmark defining sign. But blood in the urine, again, is never normal. You never want to chalk up blood in the urine to recurrent infections or anything like that without having a full investigation. Again, a lot of times when you have these masses, you don't really feel anything. You can't even feel anything on your side, but if you do feel kind of like a lump in your back or your side, that could possibly be a sign of the kidney cancer. Fatigue, unexplained weight loss, all those things are reasonable to look into it. I don't have much more on the kidney cancer because, again, it's just mostly silent, but again, if you see any blood in the urine, which we'll hit on, you should be investigated for it. So bladder cancer is very, very common as you get older, and very treatable when caught early. So there's a lot of cases of it. The average age of diagnosis is about 70 to 75. A lot of them are non-invasive and can just be treated topically, just kind of scrapings and putting in medications into the bladder. And it's a little more common in men, but not uncommon in women. So this one I think is applicable because it's very predominant in older adults. Blood in the urine, again, is the major number 1 warning sign of bladder cancer. You don't always see it, but it is important. So people who've had recurrent infections of their bladder, which sometimes happens to females, and they're chalking up, the blood in the urine to infections, you can push your doctor, your urologist, or gynecologist to do a full investigation. Sometimes you need a cystoscopy and possibly a biopsy because a lot of times they get missed due to that. So smoking is the #1 risk factors because your kidneys process all the toxins and tars in smoking. Being older, we said some of the occupational exposures, and again, chronic bladder irritation. So repeated UTIs, stones, and then a history of previous pelvic radiation is important. So we talked a little bit about, burning with urination without a UTI, kind of all those things. So again, I just want to reinforce any blood in the urine is not normal. Testicular cancer, I think, is a little less applicable, but a very common cancer in urology. Generally happens to younger men. There's kind of two peaks. Younger men, aged 15 to 35 is one peak. But there's also another peak for men between like 45 and 55. It's really survivable if you're found to have it. You can have surgery, you can get therapy if need be, but people do really well if you're found to have testicular cancer. This one is more or less the hallmark of men doing self-examinations, either in the shower, kind of teaching you guys, how to think about it or to do it. So for more applicable, I think, to this group is if you've had it before, it's still important to, or someone who's had it before, it's still important to get follow-ups later into life. There can be late recurrences of this. There are some long-term side effects if anybody's received it, getting chemo and radiation, again, and secondary malignancies, so just important to keep following up if you've ever had it. And it can also drop your testosterone later. Again, we said there's a second peak in men later in life, but it's generally just a new scrotal mass. Some of the other things are, you can feel early satiety, kind of heaviness in the abdomen. But really, this is just to highlight that monthly, self-examinations are possibly helpful, where, after a shower, you just kind of take stock of what's going on in both testicles, feeling for any hard lumps. There are some normal kind of attached structures to the testicle that may seem worrisome. Sometimes they can just be delineated with an ultrasound. But usually any hard lumps are the most concerning. And that's it for me. So, if you guys have any questions, you can let me know. But thank you again for this opportunity, and I appreciate speaking to you today. Sure, go ahead. Yeah, so the question is, what about microscopic or trace elements in blood? That's a very important question, so those need investigation as well. The guidelines usually say, a lot of times these are found by gynecologists in women. Again, don't chalk it up always to just urinary tract infections. If you're low risk, meaning, depending on your age, how many red blood cells they find, usually they repeat your urine testing. They may send it for a cytology to look for any cancerous cells kind of in the urine. Usually they also recommend either an ultrasound. Again, if you're non-smoker, it's usually just an ultrasound. Or if they're more worried, they'll send it for a CAT scan. And then possibly, if it still doesn't go away, someone should, think about looking inside the bladder with a cystoscopy in the office just to be totally sure. Then a lot of times it can be chalked up to these urinary tract infections. It's more, you don't want to discount anything, if that makes sense. But if you've been fully worked up for it and they haven't found anything, I think that's more or less a clean bill of health. So people have, bladders that tend to shed a little bit of blood or are a little bit irritated, but better to be worked up and have it be negative than miss something.
If you end up on dialysis, is that pretty much a death sentence?
That has more to do with chronic kidney disease. Dialysis is very hard on someone's body. The kidneys are kind of an amazing organ. They filter all your blood and create urine for you. The numbers for dialysis are not great. That's the truth. If you end up on dialysis, it's about every year you have a 20% risk of passing away. So if you can at all costs, keep the kidneys healthy, drink as much water as you can, keep your weight down, keep your blood pressure controlled, and if you have diabetes, keep your sugars controlled. All right.
I've got more.
Sure.
So when a patient first meets you after receiving a cancer diagnosis, what are the questions or concerns you hear most, and how do you help guide them?
Yeah, I think it depends on which cancer. I think what I try to find out is what are their goals, and me giving them as much information as possible to help them make the best decision possible. Sometimes people present with really advanced cancers, and you have to have a conversation of, we can see what happens if you get therapy, is this surgically resectable, things of that nature. And if it's really early stage, it's talking to the patient and seeing, we can be as aggressive as possible and just what really matters to you most, I think. So I think that's what I try to align with patients, and I just want to give them as much information as to what's going on with them as possible.
So robotic-assisted surgery has become more common. How does this technology enhance precision or recovery for your patients?
Sure. I wish I had a picture of the robotic surgery, but it's a new platform. It's been out for maybe like 20, 30 years or so to do laparoscopic surgery, the little keyhole surgery, but we hook up this external robot that gives us 10 times magnification inside people's abdomens. It gives us extreme control of instruments and full wristed motion, so it's like revolutionized all of surgery. It's made surgery much safer. You can get a lot of excellent surgery almost across the country because almost everybody is trained in it now, and it's more or less the standard of care, but helps the surgeons, ergonomically, helps you guys recover quicker, smaller incisions, it's all excellent.
So for those unfamiliar, how do you decide when surgery is the best approach versus other treatments like radiation, immunotherapy, or active surveillance?
Yeah, really, really just depends on the patient and their goals, and their previous histories and things like that. Some people are of the mindset, if I got something in me, I want it out of me as soon as possible. Some people also are of the mindset, I don't want to have surgery if at all possible. And then the immunotherapy or chemotherapies, really just depending on the patient, I think. And again, what are your goals? Because we want to help you. I think that's the ultimate goal. Is we don't want to hurt your quality of life in the meantime while treating you.
Is there a patient story without sharing, identifying details that captures why, the work you do matters so deeply to you?
Yeah, I think we had one recently in our clinic. We had a young Filipino male, maybe in his 60s. He'd been watched with PSAs for a long time. He had previous prostate biopsy. They didn't find anything, but his PSA kept climbing, maybe in the 12s or 15s. The MRIs only come out within the last 20 years or so. It was invented at the NIH. So we did this prostate fusion MRI biopsy. We found his cancer in a spot that they wouldn't have found otherwise. He underwent a surgery and he's doing great. And he's extremely happy that we found this stuff, and he gave us all gifts, and it was very sweet. But found something that wouldn't have been found otherwise. And I think got him early treatment and hopefully a good outcome.
That's great. So looking ahead, what gives you the most hope about the future of urologic cancer care?
We just keep getting better and better. We're finding better drugs. Immunotherapy is not really like chemotherapy, so just revving up your own immune system, and they found urologic malignancies, so kidney cancer, bladder cancer, just responds extremely well to it. So a lot of people do not feel as bad as they are when they're getting chemo. Surgery's getting better, we're getting better, we've got better drugs that are not as toxic, so medicine as a whole, I think, is just improving, and it's just helping people much, much more.
Thank you. Anybody?
Sure.
Is radioactive seed still used? I know it was used, like 30 years ago. That's still a treatment modality?
Yeah, it's still a treatment modality from the radiation oncologist. For females, I think they used to do it for like vaginal cancers or cervical cancers a little bit more. For men, they used to do it for the prostate. They still do it. It just depends on who you see. Again, what is your preference? So seeds are radioactive little pellets that are put into the organ. The benefit is it can give a little more radiation than external radiation. But there can be a little more side effects. It just depends on what you want.
So, what's the rate of incontinence with surgery these days? Because that used to be
for prostate cancer?
Decision maker for people because they knew they'd be incontinent.
Yeah.
Surgical procedure.
Yeah. Yeah, I think completely with the robotic platform. So for prostate cancer, the nerves that give you erections run behind and to the side of the prostate. They didn't even know about these nerves really until the 80s, until this Dr. Patrick Walsh did a bunch of neuroanatomic studies and found this. The robotic platform has like completely revolutionized that. It depends on the patient specifically, where their MRI lesions are, where their cancer is located, but a lot of times we can spare the nerves that give you erections, depending on where the cancer is, as well as incontinence is almost negligible at the moment. It takes it could take a couple of months, but the rates are probably like 0 to 5% of having to wear a pad or anything, past that point.
Thank you. Yesterday we were at a doctor's office and the doctor said to us, instead of me typing everything, she had her phone on and AI was typing the whole conversation. Mm-hmm. Is AI used in surgeries now at all?
Not yet. I think it's probably coming shortly. In terms of having, so Intuitive is the one that makes these robots. That's a great question. They are trying to figure it out. Patient care is always going to be the most protected thing of all possible. I don't think we'll ever trust AI or robots to do surgeries or anything like that. But I think assisting, maybe to show where organs of interest are, maybe to show where the nerves are during a prostatectomy based on the actual patient, are coming down the pipeline, but it's not quite there yet. But they're very useful for a lot of medical care at the moment. Yep.
Okay. In your experience, what is the youngest male you have encountered, and at what age that had bladder cancer?
Some very young. I think maybe even 35. It's can be a stochastic event, which is kind of random, completely random, or someone has just unfortunate genetics and just, not even poor lifestyle, it just happens to somebody young. Like I said, it generally, knock on wood, it generally happens to older people, but younger people are not immune to it.
Just a personal statement. I see the survival rates for bladder cancer. I was diagnosed with bladder cancer at age 19.
Wow, oh my gosh.
And I'm still here.
Good on you for getting worked up.
And I have 2 kids. And at Stanford, they would fight over who gets to examine me.
I mean, that's an amazing story, so I'm glad you got worked up for it. I'm glad you're doing well.
That's just to sound a voice of encouragement. And don't ignore blood in your urine.
Yeah.
It happened when I was really stressing doing discus and shot put, and really straining, and then I had the Red River.
Yeah.
And thanks to Urologic, I'm still here.
Yeah, well, again, thank you for not ignoring it, and thank you for your story.
In the news recently, there was a very well-known sports celebrity that had a treatment after his bladder was cancerous and diagnosed for removal. Can you explain more about these new procedures?
Yeah, I think that was Deion Sanders, if that's who you're referencing. Yeah, so he had his bladder removed, which I just did one of those surgeries yesterday. It's a significant quality of life impact, if you imagine, right? Your bladder's removed, you no longer have a reservoir to hold your urine. There's a couple of different ways to kind of reroute the urine. The most standard way is to bring out a little piece of bowel through the skin called an ostomy, and called an ileal conduit, where the urine just drains passively through the skin. What he had, I think, was a neobladder, so they created a new bladder out of his bowel. Those are, we do these, we do them at Banner Gateway. They're a little, I kind of liken it to having a Ford, kind of F-150 is the ileal conduit, very reliable, will last you forever. Super easy to maintain and take care of. And then the neobladder is kind of like a Ferrari. It's very nice when it works, but it's in the shop a lot and it's very expensive. So They're good for younger people who are very motivated, but they can cause some issues, and they can have a lot more complications than needing an ileal conduit. But we have a lot of different methods of doing diversions of your urine afterwards. And again, it just depends on the patient and what are they looking for. Sure. If you had a urinary diversion, they should last you forever. I mean, that's because we make them out of your own tissue. So ileal conduit should last you forever. A neobladder, if you don't have many problems, should hopefully last you forever. Just depends, if you have issues from them. You can have issues with, where we put in the tubes that drain the kidneys back into these things. Sometimes they constrict her. It'll depend, but they should last you forever. With the neobladder, it's a little bit higher, I would say, for certain. But anytime you're using a piece of valve that's now touching urine, it's like two things that we were not really intended to do. It's the best that we have. So there's a little bit higher risk of infection, but usually people do okay.
Hi, so my question today, I'm a bit younger than most everybody here. I'm about 24, and what I've heard a lot, especially regarding my generation and people around that age, is that we're looking and seeing more and more of a microplastic problem when it comes to some of these foreign entities. And while I've been able to see the later stages of, lead was an issue, and so we have people who are dealing with those complications and other more common environmental things that we've really gotten a sense of what to do with. But now I'm hearing about all of this now. This is not a history thing. This is a current thing where we have a lot of microplastics in our bodies. I'm worried that some of these risk factors could be a lot more risky, given some of that. So as someone who's younger, what are some things that I could possibly keep an eye out for myself and for people I know to have a better handle on this if it's something that's a little bit more unpredictable?
Yeah, I think that's a great question. And to that point, there's a recent study, I think, from NYU that found that patients with prostate cancer are at higher rates of having a lot of microplastic in these tumors. So there's a whole lot we don't know, and I think that's a great question. There's there's some data out there to show you where are we getting the microplastic from. There's plastic everywhere, so it's a little hard to avoid completely. I think doing some proactive things possibly, if you can, if you have the ability to, is if you can get those water filters at home that are specifically made to filter your microplastics. I think that's very helpful. There's some sort of, there's some things that may deliver more, like tea bags apparently have more microplastics than other things, so you can do loose leaf and things like that. I think moving less towards plastic where you can is probably for the best. But otherwise, if it does present, I don't think it presents any differently than the things we went over, so just staying abreast and keeping in tune with your body.
All right, well, thank you, Dr. Nethala.
Thank you, guys.
Appreciate it. So, we hope you found this informative. We're all around in case any of our guests want to have additional questions and they were too shy to ask. We hope that the standard banner and, of course, Dr. Nethala can stick around for a little bit. So, thank you again for joining us. And on behalf of all of us at Sun Health, we hope to see you at our next one.